Good morning, everybody. My name is Esther Crawley. I'm a Professor of Child Health and I lead the Healthier Childhoods theme in the ARC. I'm sorry not to be with you today. You'll be delighted to know that I also run a fatigue clinic and I'll be working clinically today. I hope you're having a great time, and I can see that I'm pretty near the end of the day, so I suspect you're looking forward to lunch, end of the day, coffee, whatever's coming up next for you. So I'll be fast. I'm thrilled to talk about the work plan for the Healthier Childhoods theme. This, of course, has been only possible because of the active and high energy engagement from our stakeholder group. So well before COVID, we thought very hard about the priorities, and in fact we took our priorities from the young people that are involved with the Healthier Childhoods theme, and their number one priority was mental health, and particularly mental health young people in schools and mental health problems that result from or are not helped by or could be helped by school policies and school interventions. So I've chosen this photo for a reason. As a young child who is alone, and as some of you are aware, some of the policies in schools about isolation, young people are not convinced that they're very helpful for their mental health. So young people wanted us to do some work on that. Stakeholders who are part of the Healthier Childhoods theme are extremely concerned about adverse childhood experiences. And for those of you who are not children, these are children's doctors or work with children. These are experiences, a wide variety of experiences that happen in early childhood that there's very good evidence for cause prolonged impact in a variety of domains as you go through life. So of course we're interested in what we can do to mitigate against these effects and identify children and help and support them. Now, the work plan was fairly decided before COVID hit, and then of course the question was the work plan still relevant? So we reviewed our priorities and our research questions, and as some of you will realise, of course, it's almost more relevant now. The issue of mental health in children and adolescents who've been deprived from the community and school and learning, and all of those factors is even more important. How schools deal with it is extremely important, and as most of you will be aware, the most disadvantaged and vulnerable children have fared the worst in this pandemic. So although the questions have been adapted slightly, they are basically very similar to the questions that we initially set out with. And I'm just going to go through the questions now and talk to you about some of our plans. So how have schools responded to reduce mental health problems and promote positive mental health in response to the pandemic? So we use a mixture of approaches for this, including a study that's currently running and interviews with stakeholders to really try and identify what approaches have been helpful. We've already conducted an evidence synthesis, so then the next stage would be to classify the interventions that have been used and identify if they're likely to be helpful or not, given the evidence that is already available. In terms of the adverse childhood experiences, we intend to do some work to really try and understand what the economic impact is of those experiencing adverse childhood experiences. This is very important for commissioners who need to understand how to prioritise limited resources. And then the next question that I think is very interesting is, given what we know about the evidence of interventions, what are we actually doing and what should we be doing, what should we be doing less of in terms of mitigating the impact of ACEs and possibly preventing ACEs. We will be using routine data to see if that is an effective and feasible approach to guide the responses of vulnerable children and families, and there is some particularly interesting routine data that is available in Bristol. And then the final study will be looking at how services respond to the needs of vulnerable children in lockdown, and that will be a further qualitative study with stakeholders. That's our work plan that I'm excited about and that we're going to be doing. And next up, you've got what's going to be a really interesting talk, and I'm sorry to miss it, with Rachel about trauma-focused CBT. If you have any questions about this, please ask John McLeod. Thanks, and have a great end of your day.
So that was a Great presentation from Esther, who's really sorry that she can't be with us. Without further delay, I'll move on to Rachel. Welcome, Rachel. Handing over to you.
Thank you very much, John. I'm presuming people can hear me and that someone will just jump in if you can't. I've just got to share my screen. Okay, so again, I'm just going to presume you can see this, and please, someone on the panel jump in if you can't. So I'm just going to talk for about 10 minutes today um, on some research we've been doing around addressing the trauma-related mental health needs of young people in care. And this research has taken place in the Southwest, of course, with almost all of our local authorities actually in the region. So just to provide some very brief background on what we know about young people in care. So there are around 70,000 young people in care in England. And of course, what many of you will know is that the most common reason a young person would be moved into our care system is due to exposure to very significant and unfortunately often very prolonged maltreatment. And alongside this, they've also very commonly experienced many, many other adversities, um, all these issues that we already know are risk factors for poor outcomes for young people. And that might be poverty, missed early education, parental drug and alcohol abuse, etc. In England, most young people enter our care system from school age or older, and actually adolescence is the fastest growing age group entering care at the moment. So as I said, these experiences have often been very prolonged. I think it would also be remiss of me not to also say that moving into care isn't a magic cure for what some of these young people have experienced. So many young people in care actually identify the process of being moved into care as one of their most traumatic experiences. And once in care, instability is relatively common. So separation from siblings is relatively common, as are lots of changes between carers or placement providers. So a bit of a melting pot you can see here of some very, very difficult early experiences. And the scale in terms of the consequences of this is very well known around young people in care. So we know, for example, that they're 5 times more likely to meet criteria for a psychiatric disorder compared to their peers. And we also know that their unaddressed mental health needs are considered a really key driver of many of the outcomes that we see across the lifespan for this group. And that includes things like very high rates of school exclusion, right through to adulthood. We see higher rates of homelessness, unemployment, very high rates of self-harm. And what this also means is that there's very high rates of utilisation of our social care and NHS systems as well. And before I move on to the next slide, I also do want to make sure I highlight that some young people in care do very well. They really flourish in that system. They have very good outcomes, and I don't want to lose this. I'm always so acutely aware that my talks of, because I'm looking at mental health outcomes, can be quite negative in focus, but it's really important to also remember that some young people in care do very well. So before I get on to our proposed ARC project, I just wanted to give some brief background about the research that my team and alongside some wonderful colleagues have been doing around the mental health of young people in care. So we've been looking at a variety of questions over the last few years in projects that were funded by the ESRC and currently NIHR, and also MQ Mental Health Charity. One of the questions we've been interested in is how mental health difficulties develop once a young person enters the relative safety, we hope, of the care system. And so we ran some research very recently with 3 of our Southwest local authorities where we pulled social care service data to have a look at how emotional and behavioural difficulties develop over the first 3 to 5 years in the care system. And essentially the take-home point from this was that if a young person enters care with existing emotional and behavioural problems, which is the case for almost half of young people in care, those same problems are very likely to be there 3 to 5 years later. So kind of recovery trajectories were far less common. The other quite large piece of work we've done over the last few years is looking at what the key predictors are of mental health difficulties in this group. And that has been a specific focus on post-traumatic stress disorder, which, as many of you know, is a trauma-specific mental health disorder. Rates of PTSD in this group are 12 times higher than in the general population of young people, and studies place between kind of 30 up to 70% of young people in care as experiencing high symptoms PTSD. And so this was certainly a project that was developed alongside young people in care, and also particularly alongside services, where we have very well established cognitive behaviour models of PTSD that our treatments are based on. But there's a very strong belief that these kinds of models are not applicable to young people in care, because undoubtedly their experiences have often been very complex, and there's often a lot of ongoing complexities in their care. So we quite simply just wanted to have a look at this. So we wanted to have a look at whether existing cognitive behaviour models of PTSD were applicable to this group. And we did this via a longitudinal study that's published open access. Sorry, I should have put a link there. Sorry, I'm happy to share a link later. And the take-home point from this body of work was that absolutely our cognitive behaviour models of PTSD were found to be highly applicable to young people in care, including when we looked at it under a new complex PTSD framework. Complex PTSD is a new diagnosis that has somewhat controversially been provided in one of our diagnostic manuals only very recently. So those models were very applicable. We found that how young people cope, and also particularly maladaptive appraisals about their early experiences, were very strong drivers of their PTSD symptoms, and were far stronger drivers than how objectively severe their early maltreatment was. The final piece of the puzzle here that we've looked at, particularly with qualitative methods, has been looking at individual and service level barriers and also facilitators to help seeking in this group. So that's been with qualitative work with young people in care, and also with carers, and then very extensive consultation with different services around the care of these young people. Trying to understand a little bit more about how they're managing in these many quite complex systems to navigate, not just in terms of trying to seek formal mental health support, but also just how they're managing day to day with things like interpersonal conflicts or other difficulties that might arise. So this leads me to a proposed project that we've having reviewed at the moment as a cross-ARC project, being led obviously by ARC West. And this is to look at the cross-sector implementation of trauma-focused cognitive behaviour therapy. And this is kind of one branch of the research my team's been doing, which kind of reflects this culmination of the evidence we've gathered over the last few years. And that is that we know there's very high rates of PTSD in this group. We know that the same models of PTSD that our treatments are based on are very applicable to this group. We have a well-established treatment for PTSD for young people in trauma-focused cognitive behaviour therapy. But we also know that for our young people in care, PTSD is rarely identified, and even if it is identified, trauma-focused cognitive behaviour therapy is rarely used as the treatment of choice for varying reasons that we're hoping to unpack. So as I said, we're proposing a cross-sector implementation project for trauma-focused CBT. And that would be working alongside services. So we're not looking at changing service provision in any dramatic way. We're just wanting, if a young person in care goes to their service and is screened as experiencing PTSD, that trauma-focused CBT is delivered. It's not a randomised control trial, it's just a pure implementation trial within our services. And those services cover CAMS and also our specialist CAMS, which we have in the Southwest, but also third sector and social care mental health services. So for us with this project, it's really important that we're implementing the treatment where these young people are going, which is sometimes, but absolutely not always, CAMS. And the project has two key aims. Firstly, obviously, we're really keen to identify the barriers and facilitators of services delivering this treatment. And that might include individual level, so child level variables, clinician level, and also service level predictors of using this treatment, but also fidelity to the treatment manual. The second aim within this is that this kind of work would also allow us to add some really useful information, I think, to the evidence base for trauma-focused cognitive behaviour therapy. Firstly, by obviously having a look at how symptoms reduce in this specific group of young people, not just PTSD, but also this new complex PTSD framework. But perhaps even more important than that, having a look at some basic predictors of treatment success in this group. And that might include things like IQ, where we know we see it, many young people in care with particularly mild to moderate intellectual disability. but also their initial symptom severity, and particularly importantly for this group, the involvement of their carer in trauma-focused CBT. So trauma-focused CBT would traditionally have a parent involved in it, but for various reasons that may or may not be suitable for a young person that's in the care system. So that is a snapshot of the work we've done and the work we're hoping to do over the next few years. And I think I'm going to move on to questions.